Hello to everybody. Thank you so much for letting me come and tell you about my research. As you can see, I'm the Chief Admiral Nurse and CEO of Dementia UK. And if I haven't got enough to do, I'm also doing my doctorate, and I'm in the latter part of my doctorate. And in particular, I'm looking at behavioural variant frontotemporal dementia, or PICS disease for short. I'm supervised by a couple of people, professor and a doctor over at the University of Northampton, the Institute of Health and Wellbeing. But I'm also working quite closely with Dementia UK and with Northamptonshire Healthcare Foundation Trust. What I'm planning to do is I'm planning to go into the outline of my research. I'm also going to acknowledge the work of Jennifer and Jackie, and thank you very much, because actually it leads in really very nicely. And after that, I'm going to leave quite a long period of time for questioning, because very often I find that people want to ask quite a few questions. And I'm hoping also to be able to bring our timing back in a little bit. I'm going to be here for lunch, so if anybody, and I'm going to be here till the end of the day, so if anybody wants to come up and have a chat with me over lunch or after, and I will also give you my email address and my contact number, I'm more than happy to do so. So, overview, introduction. I decided that I would actually start looking at PICS disease. Why did I start doing that? I've actually been working in mental health for 34 years now, and in particular, I've always had an interest in dementia. So most of my career has been spent working with people with dementia across the age range. In 1999, I started to specialise in people under the age of 65. And as I started specialising in people under 65 with dementias, I then became really interested and became a nurse consultant. And I set up the first service for Northamptonshire for younger people with dementia. So that's where I'm coming from. This is where my interest would lie. Oops, I've gone the wrong way. Young onset dementia, as you know, accounts for about 2.2% of all people with dementia in the UK. Quite a small proportion. But often you find that the sorts of dementias that people under the age of 65 have actually can affect the whole family unit significantly, mainly because they're rarer types of dementia, usually as well because people don't recognise that this presentation is actually a dementia, and it can actually take a long, long time to get the diagnosis because of that. So families can feel the pressure for a series of 3 to 5 years before you actually get a diagnosis, and I'm sure some people in the room have been in that position. Estimates are saying that there's around 17,000 people in the UK with young onset dementias. I think that's the tip of the iceberg, because from when I set up the service in Northamptonshire, my predicted numbers was 212. We were far in excess of that within 2 years of me being a nurse consultant there. So I would say, true figure, likely to be a hell of a lot higher. Dementia isn't just a disease of old age. We all know that. It is more common, and the presentations are going to be more common as you get older, because certain dementias are actually more common in the older person. For instance, Alzheimer's disease, vascular dementia, you're more likely to see over the age of 65. But that doesn't mean to say that you won't see those presentations under the age of 65. But when you do see them, sometimes there's a genetic component, i.e. there's a familial incidence, and that has its pressures as well. So, like I said, I'm experienced in actually working, assessing, diagnosing, actually offering advice, support, and putting services in place. And when I first set up the service, I worked on Admiral nursing principles. So it's kind of ironic that I'm now the Chief Admiral nurse. Northamptonshire was never so go ahead that they'd have an Admiral nurse, and they thought, well, why do we need one? Because you're doing what you need to do, so we don't need to pay for an Admiral nurse. So Admiral nursing experience. Does anyone know what an Admiral nurse is? Has anyone experienced Admiral nurse service? Just a few of you. Well, basically, that's a nurse, a specialist dementia nurse, that works with the whole family unit. So my experience has been working with whole family units. It's not just diagnosing the person living with dementia, supplying the treatment for the person living with dementia. It's actually working with that whole family to make sure that the person can live more effectively with dementia, and the family unit can too. I started getting really interested in frontotemporal dementias. And the reason I started getting very interested in that is because the presentation, as you all know, is very different. There'll be some people sitting in the room that have got the life experience of actually having somebody with a frontotemporal disease within their family, and have possibly got parents or grandparents that have got Alzheimer's disease. And what do you notice from that? Anybody? What's the differences that you notice? It's part of a person's lived experience, so the public understand that a lot easier, don't they? So therefore, you tend to get more support. I'm not saying the support's brilliant for the over 65s or people living with Alzheimer's disease, but it's better than you often experience with frontotemporal conditions. And it's that started me getting really interested in frontotemporal conditions. And in particular, that's why I made the decision to actually concentrate on that for my doctorate. So the presentation is very different. Takes a longer time for diagnosis, 3 to 5 years on average for somebody with a frontotemporal condition. You often find that the family unit, when they've tried to say there's a problem with my spouse, with my mother, with my father, whoever that person is, other people have said, oh, it's probably work issues, or it's probably a relationship issue. Have you thought about going to see Relate? Have you thought about changing your job? Those are the common things that people say because they don't necessarily recognise that this is a dementing process. Family distress, I noticed, is significantly higher with the under 65 age range than the over 65 age range. Anybody, any particular reasons do you think there might be for that? Why? Financial, teenagers, all of the things that we're trying to juggle. So keeping a job of work down, bringing a family up, the finances, having a mortgage, kids going to university, all of those aspects are life stressors. So you often find, add to that somebody that's showing symptoms of a frontotemporal condition, that can actually be one thing too many in effect. So I wanted to look as well at, do the social groups, do your social networks support you? Does the family support you? Do people that were there for you in the good times, are they there for you in the times that become more problematic? And that's what my research is telling me. Surprise, surprise. You would think that's common sense, but actually there's only one other article at this point in time that's writing about the social connectedness or it's talking about the lived experience of a family with frontotemporal condition. So that's an area that I wanted to really look at. And I wanted to find out, in those situations where the social networks have remained relatively intact, or a different social network has started, what makes them work? What makes that different to somebody else that gets no social support whatsoever? So that's another area I wanted to look at. Most of the research, and I know there is at least one other person doing research into FTD in the room, and 2 in semantic, but there was semantics. When we look at the current research, what it tends to concentrate on is the pathology. So what happens to a brain when you cut the brain up after the person's passed away and you have a look at the brain? Or the presentation. These are the symptoms. Well, we know that all too well if we're living with this particular condition. The biochemistry. What goes wrong with the biochemistry? What can we do about the biochemistry? Or the genetics. Very, very little in the qualitative aspects. Very little on the lived experience, like I was saying. Jennifer quite rightly pointed out, a lot of the features that we notice with the behaviours is because of the changes in the frontal lobe. So behavioural variant frontotemporal condition is Pick's disease, so mainly affects the frontal lobe. Although, as Jennifer quite rightly pointed out, if you've got those 2 overlapping circles, there's a bit in the middle where you will sometimes get a crossover of symptoms. So it's difficult to judge which one has got the supremacy in effect between the semantic or the frontal. But most particularly, if you look down those lists, I'm not going to read every single one of those out because we've covered them before, what you will find is those are the sorts of behaviours or the features that the social network will notice about the person living with the diagnosis. And it's also what the social network will avoid, if at all possible, because it makes the person feel uncomfortable at times, or it might make the person a little less socially acceptable. So not only do people start to withdraw from the person living with the condition, but actually they can start withdrawing from the family unit. And I notice when I'm doing the research, that's being fed back to me. So I want to look at, so what could we do about that? How could we improve that? So the particular topic or the aim I'm looking at is exploring the social context of living with behavioural variant frontotemporal dementia. It's an interpretive study because I want to find out what the lived experience is in the context. And it's trying to find out what people are actually feeling within that unit. It's not just about the person that's living with the diagnosis. It's also about the family members, but it's also about the wider network. How does the community respond? How do the employers respond, for instance? How do church groups or faith groups respond? How do social groups respond? And that's the bit that's been really quite interesting when I've been doing the research, because there's been some surprises there, and we'll go into that in a few minutes. So, social connectedness. As you can see, there are a lot of different agencies in effect, or people or organisations that actually are working around the person living with dementia. So you've got your family unit, they've got the work environment. Some people are still in work that I see, but that is usually a very small proportion. Majority of people have already left work, and sometimes it's because they've been made redundant, and sometimes it's because they've been moved sideways, or sometimes it's just that there's a misunderstanding as to why the person isn't performing or is performing in a certain way within their workplace. Looking at the social networks, looking at the spouse, looking at the relationship between the spouse, and in particular the work that Jackie was talking about the kind of the communication patterns, whether that's verbal communication or non-verbal communication, and how the responses the relationships that you can actually observe as well. Looking at neighbours, some neighbours are very supportive, some neighbours are not quite so supportive. In fact, some neighbours can be very, very poor at being neighbourly, shall we say. Faith groups. You would expect faith groups to be very, very supportive. This has been my biggest surprise out of all of the research that I'm doing. Faith groups don't tend to be as supportive as I would have expected, to be frank. Because of behaviours, partly, when you're in any sort of congregation or any sort of gathering, if the behaviours are, shall we say, antisocial at times, very frequently you're finding faith groups are saying, well, actually, it's nice that they're coming along, but do you think that is probably a bit too much for them now? Yeah. It's a little surprise, like I say. And friends, looking at friends. And friends, some fall by the wayside. And sometimes some people are getting new friends because of what's actually happening. Finding people that they would have classed as acquaintances before, but actually have turned up trumps when the diagnosis has occurred. So I'm doing case study research, and the case study research I actually chose a case study because I wanted to look at things in depth. I wanted to look at things in the context of where the situation is occurring. I wanted to look at individual cases, but I also wanted to do the cross case as well. So I actually wanted to compare cases to look at the themes that are emerging. Because what you find is you don't tend to have one family that is unique. You tend to have themes that are occurring across the families that I'm seeing. I looked at semi-structured interviews, so I'm doing semi-structured interviews. I'm doing that with the people that are around that circle that I showed you, that the spouse, the family unit, and also the person living with the diagnosis. I'm also looking at participant observations, and that has been quite eye-opening. You have some communities that are very dementia-friendly, although sometimes, although they're dementia friendly for Alzheimer's. They're not necessarily dementia friendly for somebody that kind of bursts into song, or someone that kind of exhibits certain behaviours that possibly aren't quite so accepted. I also noticed as well that often families will start to naturally reduce the social network, particularly in the local community. So, for instance, if you know that Costa Coffee is not terribly good when you're taking your spouse out, you tend to avoid that. So you tend to find that people start to limit their social network out external to the home. The other thing is I'm asking my relatives to keep a record of thoughts and feelings, and that's usually written diary, or it can be an audio diary, or it can be emails, whichever the person feels comfortable to do. And that has been really eye-opening. I have got some fantastic diaries back. I have one that's that thick, and it's like in an A4 file, and it's called Pretty Woman at 5. And this particular talks about the experience of always having to have Pretty Woman on at exactly 5 o'clock. He has got through 8 DVDs. They're now completely obliterated. He's got another 8 because he knows that if ever he had a problem where he couldn't get Pretty Woman, there would be a problem with his wife. So it is absolutely fascinating. And what that's revealed is actually, when he's looked back over time, the symptoms started a good 20 years, not just a few years, before diagnosis. So that's a really fascinating account. And I thought this is probably just a one-off. Second one I got through, 15 years. So what that's indicating is actually, you know, the current research that's saying, oh yeah, about 3 to 5 years, symptoms only start at that point, looking at the lifespan after diagnosis. To me, that seems to be indicating in the families that I'm looking at, actually, you've got a much longer period of time where frontotemporal conditions can actually affect a family and the person living with the diagnosis. And you know what, those of you, anyone who's been involved in research, you know what it's like. You keep getting little bits and you're thinking, right, I've got to focus on that research, but something else comes up and you think, oh, I'd really like to look at that as well. I really like to look at that as well. And I think at some point we'll be writing these up. So when I'm getting all the information in, what am I doing with it? Well, I'm using thematic analysis. In other words, what you do is when you get all your information together, you try and search through for themes. Just try and find if there's anything there that's a pattern. And you're doing that for the individual case, and then you're taking each of the other case studies and all of the evidence that you've got from the interviews, the participant observations, diary, and you're bringing all of that together. And once you've got your themes, and that takes you some little time, I have to say. Once you've got them, you start to define them, to name them, to test them through, and then you start to produce your report. And what's emerging so far? Well, these are the themes that are emerging. Realisation. The realisation that something is not quite right. And the realisation, for some people, is 3 to 5 years. For some people, it's 10, 15, or 20 years. And it's often only you realise that it's 10, 15, or 20 years in hindsight. It's when you've got the diagnosis and then you look back. Okay? So the realisation something's not quite right. And often when people get that realisation, it's a thought of, particularly from a spouse, is it a marital breakdown? What have I done wrong? Why is this kind of relationship not working? It's also, there's a realisation there's something wrong, but actually, who do I go to? Is it a relationship issue? Is it a work-based issue? Is it a stress? Or is it a physical issue? And do you know what every single person will say? They didn't think of dementia. Why don't people think it's dementia? Well, quite obvious. When you go to somebody, a GP in particular, and you say, I think I've got dementia, what do? Test your memory. What have you all noticed? 100%. Spell world backwards quicker than I can spell it world backwards. Yeah. So basically people go backwards and forwards, and I know that Jill's going to be talking about this afternoon, so I won't steal her thunder, going backwards and forwards to health professionals to get a diagnosis. And you all know what that feels like. Isn't that frustrating? So, realisation. Getting other people to realise is a sub-theme of that. Difficulty in getting the diagnosis, most definitely. It takes perseverance to do that. But once you get the diagnosis, did anyone go through this stage? Rejection of the diagnosis. Can't be right. Too young. They're too young. Can't be right. Something else must be wrong. Probably wanting another scan, probably wanting another test. Testing out with other people. Do you think there's something wrong? Testing it out with other family members. Testing it out with local community. Then there's the embarrassment. And again, some of the behaviours can be complex at times, and therefore people can get very embarrassed by the behaviours. And the families, it doesn't, although there is a certain extent the environment starting to withdraw because they're embarrassed by the behaviours, they don't know what to say, all of those sort of aspects. There's also an element of families withdrawing as well, stepping back from, because they don't want to face the embarrassment or the feelings that they're going to have when they're out and about with the person. People that do the best are the people that have the use of humour in families. So they think, okay, right, okay, so they're going to do that, fine, and have the use of humour. So they actually will work with the person. Or will explain when they're going to somewhere what some of the issues are going to be. Anger and frustration is a common emotion. Anger and frustration about everybody around. Anger and frustration against the person that's living with the diagnosis. Anger and frustration with themselves. Anger and frustration with the world in general. This should not happen at this time. We shouldn't have expected this to happen under 65. We're supposed to have had a good retirement. These are comments that keep coming through and through and through. But then, starting to feel guilty about the fact that you're angry and frustrated, starting to feel depressed about what's lying in front of you, all of those sort of features that people will live through. And again, the way people deal with that, for instance, having advice and support, having supportive network, having some sort of respite, makes the difference between a family unit that's living with the diagnosis, living well with the diagnosis, and a family unit that isn't going to be coping. A lot of people say the change in relationships is difficult. Sometimes people say the change in relationship is more positive, depending on how the personality has changed. But the change in relationship from being a spouse or being the son or daughter into being a carer, people can find that really quite complex unless they've actually got the support to be able to do so. Change in social networks. Like I said before, some social networks will start to withdraw, but again, people that are coping better, it's usually they're finding different social networks. Do you know what's coming out the best out of all of this for actual social support? Which group do you think comes out the best?
Singing for the brain.
Absolutely, spot on. Singing for the brain, and we've got somebody talking about singing later. It consistently comes out as a real positive thing that people can do. And yet, coming back to what Jackie was saying, but they never used to sing. I'm amazed they know the words to that because they never sang. I've never heard them sing before. So yeah, singing is a really good one where people can actually start to engage. And grief, inevitably there's going to be grief within the situation, within the themes that are coming out. And usually that's expressed within the family unit and occasionally from siblings that I've been interviewing as well. So Timescale, I'm actually just about recruited all of my participants now. I'm looking for one or two more if anyone's interested, and I've got my details on the back. So recruiting participants, I'm conducting interviews at the moment, observation visits, collection of diaries, analysis, under a sea of paperwork as you are when you're doing this sort of thing. Just starting now to arrange my follow-up visits to discuss the results and preliminary results for each of the individual units. And then once I get to the stage where I've got all of my case studies in, then I will be going out and discussing all of the kind of matched units as well. And finish up writing my research in May 2015. And yeah, well, that's a hope. So what have I picked up in conclusion? The one thing I think is most important, and for any health professional sitting in this room, listen to the family. The family know best. If they are saying there's problems with the behaviour, or there's something very wrong here because they're having problems at work, or they're doing things that's really out of keeping, please listen. Because so frequently, in fact, every single couple I've spoken to, the family hasn't been listened to. Awareness. We've got so much work to do as health professions, getting the awareness up there. And I was really glad what Jill was saying about increasing the awareness. The awareness for GPs in particular significantly needs to rise. We have an occasional GP that does very well, and we have some that are inadequate, to be frank, when it comes to spotting FTD. Early diagnosis. Why do I think early diagnosis is so important? The reason early diagnosis is so important is so you can make plans, so it gives you, you can get an understanding of why it is that a particular presentation is as it is, so that you can actually start to get the advice and support you need. But again, as Jill said, we need to increase the advice and support available, because what's there for Alzheimer's disease isn't necessarily going to be what you need with living with FTD. So we need to do a lot more work around that. Identifying a clear pathway. And that's a biggie, because what I see going around the country is you have a dementia pathway. There's a little bit with social services, and there's a little bit over here with this particular voluntary group. There's a little bit with the National Health Service. There's a little bit with the GP. There's no joined upness. I met a person last week, and she had 52 different people involved with the care of her daughter, who's 37. How is that appropriate? So what I'm saying is we need to have a much clearer pathway, a dementia pathway that goes all the way through, so you know who should be looking you can go to and who should be looking after each of the stages. Access to specialist advice and support is very important, because if you don't have the specialist advice and support, as you quite rightly said, Jackie and Jennifer, often you get lots of different advice and it's actually not pertinent to the FTD or what you're living with. What you get is lots of different viewpoints that's based on different diagnoses. If you had heart disease, you wouldn't expect someone to give you information on cancer, would you? But that unfortunately is what we do. So thank you for your interest. I'm happy to take questions. If anybody's interested in being part of the research, or if anybody's interested in asking me questions, please email me, please give me a phone call. I'm more than happy to do that. I've also included Admiral Nursing Direct, mainly because I'm aware that obviously sometimes people want advice and support, but they're not necessarily attached to any service with frontotemporal disease. So if we could actually kind of use that number, and they can point you in the right direction of who you need to speak to.